This is Samira Daswani, the host of the podcast, The Patient from Hell. I have a very, very cool guest with us today. This is Dr. Kozower with us, who's a thoracic oncologist and surgeon, I should say, and a researcher who's going to be spending time with us talking about both the clinical side and the scientific side of his practice. Welcome to our show.
Great. Thank you for having me.
Why don't we start, Doc, with where your name comes from? I don't think I've ever met anyone with your last name.
I believe Kozower is actually a town of goats in Poland. My grandparents came over right before the Second World War.
Oh, wow. Did I hear you say town of goats?
Yeah.
All right. You've been here ever since?
Yes, my parents moved around a little bit while my father was training. He's a physician as well. I was born in Boston and have lived my whole life in the U.S.
Interesting. How did you end up being in oncology?
I ended up in thoracic surgery. First of all, my father's a physician. Both of my grandfathers are physicians. So I think that obviously impacted it. And then my mother actually had lung cancer when I was in elementary school. She had one of the few types that's not associated with smoking. Unfortunately, she's a lung cancer survivor. It's been quite a few years since that. And so I think, obviously those things played in. And then when I was doing my surgery training, I really was more drawn to longer, more intricate cases. The pathophysiology of the heart and lungs really fascinated me.
Can you talk a bit about the use of surgery in lung cancer? And I ask that with the following backdrop. We're sitting in a world where there's so many new targeted therapies now available. So how do you sort of see the role of surgery as it's been so far, and how do you see it going forward?
Yeah, there's many different roles. Traditionally, surgery was used for early stage lung cancer, patients who have small tumors typically confined to the lung, when hopefully it can be curative. There's also a role sometimes for surgery to help make a diagnosis when a patient might have a nodule or a mass in their lung. And, despite best attempts with needles or bronchoscopies, putting scopes through the airway, you're still not sure what that is. And then also with the way the field is moving, we'll probably be more involved in even more late stage cancer. Patients responding much better to some of the therapies we have now called immunotherapy, and some of the combinations with chemotherapy have had dramatic effects. And then there's, one foci, one nodule left, or one lymph node left, something like that, or one site of disease. And so many patients who traditionally didn't get lung cancer surgery may end up with surgery in the future.
Interesting. Can I maybe ask you a follow-up to one of the uses of surgery you mentioned, which for me is fascinating, is the use of surgery in the diagnosis of lung cancer. And the context there for me is, I mean, I'm a breast cancer survivor, triple positive breast cancer. So I never had to grapple with surgery before diagnosis. It was always used as a modality for treatment. So I'd love for you to talk a little bit about that, and like, where did that come from? Why exactly do we do it? How do you decide if you need surgery up front or a biopsy, like a traditional like bronchoscopy driven biopsy, and anything that would be?
Most commonly, patients have a diagnosis before we go to the operating room, but probably 10 to 20% of the time they don't. And that's often more common for early stage lung cancer. If you have a patient with a very strong history for lung cancer, a smoker, you have serial imaging showing a nodule that's enlarging, that has characteristics of a lung cancer, it's spiculated, things like that. You have a PET scan which shows that it's positive, kind of like we call it the pretest probability, the chance that that's a lung cancer almost becomes overwhelming. And sometimes you have a needle biopsy or something that it's non-diagnostic. So are you going to continue to wait while it really, all the evidence in front of you shows that this is most likely a lung cancer that's enlarging.
Fascinating. So in that case, where the pre-test probability is theoretically high enough that essentially we're making an educated guess that what we're seeing on imaging or with symptoms most likely will be lung cancer, you go straight into a surgery and you remove it.
Yeah. And typically we do a smaller operation to confirm the diagnosis.
Hmm.
And we can actually, while the patient's asleep, a pathologist can look at a smaller sample, confirm the diagnosis, and then we'll do a more formal cancer resection.
I see. Interesting. And then how often when you are looking at when the patient is already underway in surgery, how often are you seeing that? How often are you confirming the diagnosis? I guess is my question.
I'm sorry, I'm
And how
not
often are
clear.
you?
How often?
So, for example, just so that I understand this, patient comes in, there's a pre-test probability, but we're not sure it's cancer. Patient goes under surgery. We open the patient up. You take a sample of the tumor. The pathologist is there. The pathologist looks at it and either confirms or doesn't confirm cancer. Right.
Yeah, that
So,
probably happens about 10% of the time.
wow. Okay. That feels very daunting to me. It feels truly daunting. That feels like a very daunting surgery to walk into. Because you're sort of walking and going, all right, I'm going to wake up and either have a cancer diagnosis or I don't, and either it's going to be gone. That feels very daunting. Wow. Okay. Huh. Fascinating. And then in the late stage settings, actually, before I go to the late stage settings, so that's 10 to 20% of the time. But the rest of it, patient has a confirmed diagnosis based on biopsy. And then how is surgery playing into that decision for an early stage lung cancer patient?
Yeah, surgery is the traditional treatment for early stage lung cancer. It accomplishes a couple of goals. So first, it removes the tumor with a healthy margin, some normal lung tissue between the tumor and what's taken out. And the other thing it does is called mediastinal lymph node dissection or nodal sampling, because lung cancer can spread to the lymph nodes. And the only way to know that is if you sample them, if you actually take some out and the pathologist is able to look at them. So a lung cancer resection accomplishes both of those goals. And then you get a final stage from the pathologist when they're able to look through everything.
Got it. And how is the treatment decision happening kind of upfront? So actually, before I go down that route, I'm assuming that when we're talking about this, it doesn't matter what type of lung cancer a patient has. So as long as it's
Yeah.
early, not small cell,
Yeah.
small cell, it doesn't really matter.
No, it actually matters quite a bit. So non-small cell lung cancer is by far the most common, about 80% of lung cancers. And that's really what we're talking about. And last year, it was about 450,000 patients, diagnosed with this in the U.S. So, it's fairly common, not near as common as, breast cancer or colon cancer. And so we treat non-small cell lung cancers, particularly those that are early stage. The primary treatment is surgery. Small cell lung cancers occasionally have surgery as part of the treatment, but much more frequently are treated in a non-operative way with what we call definitive chemotherapy and radiation therapy. So most of the surgeon's role is in non-small cell lung cancer.
Interesting. And why is that? Like, why is there such a big difference?
The biologic behavior in that small cell lung cancer typically presents later stage and has a predilection to already be in the bloodstream. And so, surgery is a local therapy. We can treat, the lesion we see in the lung, but we obviously are not treating anything in the bloodstream. And so because small cell is a systemic disease, the mainstay of treatment is, chemotherapy and systemic treatment.
Interesting. And then does the type of non-small cell lung cancer matter?
It does matter, but most of them are treated the same way. So there are many different types. The most common are adenocarcinoma and squamous cell carcinoma.
Interesting. But it doesn't matter from a do you do surgery or not do surgery perspective.
Correct.
Got it. Got it. Okay. That is super helpful. So I'm going to quickly summarize and then ask you another question. So
Okay.
patient shows up, early stage being stage 1 through 3. It's in the lung only, it has not spread. The patient, we've decided that based on a bunch of imaging and testing. Patient comes in and primary goal in this setting is to first do surgical resection, i.e. remove the tumor plus some healthy tissue around the tumor.
So that's true for stage 1. I think you mentioned stage 1 through 3. So early stage lung cancer traditionally was kind of stage 1 and stage 2. So stage 1 is you have a cancer in the lung with no lymph nodes involved. And stage 2 is you have a cancer in the lung with lymph nodes that are essentially in the lung involved. And then as you progress, stage 3, cancer in the lung, lymph nodes out of the lung. Typically, we talk about something called the mediastinum, which is the middle of the chest near the trachea and the esophagus. And then stage 4 is it's spread distantly to other organs. And so in 2024, when we really talk about early stage lung cancer, we're really talking more and more about stage 1 lung cancer, that it's just confined to the lung.
Interesting. I see. So in stage 2 and stage 3, does surgery play a role?
Yes, it does play a role, but typically it's not the only treatment. And so it's recommended, for stage 2 that you would give adjuvant chemotherapy or chemotherapy after. And now we have several trials over the last few years that actually show you can give chemotherapy with immunotherapy before surgery with excellent results. Those are the checkmate studies, and that's what's commonly used, and particularly for stages 2 and 3.
Got it. Okay, so that is super helpful. So it sounds like, let me just make sure I'm now summarizing the right way, is stage 1, you're primarily looking at surgery as the primary modality, plus minus stuff, but primarily, most often, that's what's used. Stage 2, stage 3, it's surgery plus some sort of systemic treatment. And that's where I'm assuming the molecular subtype of the cancer does start to matter quite a bit.
Yeah, and typically when we know it's stage 2 or 3, we're giving those other treatments first. Right? Sometimes you go in and you're a little surprised either in the operating room or on a final pathology report. And in those cases, you'd give chemotherapy or immunotherapy after surgery. But if you know going in, then you would do those treatments up front, followed by surgery.
Got it. Okay. All right. So I super appreciate that color because I know we're supposed to be talking about the PCORI study. And I think it would be really hard to understand the value of the study and the results without having done the sort of backdrop of like understanding the basics of early stage non-small cell lung cancer. So given what we just spoke about, how do you think of the research that was published with PCORI's funding?
Yeah. So we actually did multiple studies, but the idea is looking at lung cancer surveillance. And I should add that we actually started off as a group wanting to do a program project with a breast surgeon and a colorectal surgeon and a prostate radiation oncologist. Because cancer surveillance, following up people who have had cancer is an important part of care. And, now we call it survivorship. How do you help these people after their primary treatment? And so actually all of us were funded, but we're funded separately. So it's not on the same grant, but we worked together. And the first problem is when you want to look at surveillance, so you have to understand the intent. And so big picture, for people who aren't familiar with what we did, everybody's followed after their cancer treatment. What's not clear is how often should we follow people? And if we talk about lung cancer specifically, different societies have different guidelines. Initially they recommended even different studies. It started off in the 80s and 90s and even, until about 10 years ago that chest x-ray was one option. Now it's moved to CT scanning. So everybody uses CT scanning. But how often? Should you see a patient every 3 months? Every 6 months? Once a year? And why does that matter? Patients, given the option, want to be seen typically as frequent as possible, with this idea or a belief that the more frequently I'm seen, the earlier something could be detected and the better I'll do. Makes
Yes.
perfect sense.
Mhm.
Unfortunately, I'm not sure it's true. And our data does not prove that.
Yeah.
And it's also important because these appointments accompany a lot of anxiety. You know, the week before patients come in, you're thinking about it and it weighs heavily on you. People don't sleep, people have to travel. So there's that side. There's also the actual cost, you know, to the patient and the healthcare system. If you're, you know, scanning people, you know, 4 times a year instead of once a year, it adds up. And if it's helpful, then great, then it's worth it and we should do it. But if it's not helpful, you know, you're talking about a lot of financial costs, psychological costs. And so that was part of the impetus, you know, for this study.
Hmm.
And so what we really wanted to do is see if the intensity of surveillance was associated with survival after treatment for lung cancer.
Okay, so that makes a ton of sense. I can absolutely validate the patient side of this. I have a scan. I mean, I'm a breast cancer survivor, so for me, surveillance is mammograms and then whole breast ultrasound, and my scan's coming up in a week. And I'm like 3 years out. This should be like, you know, old news by now. But oh my God, is it anxiety inducing? It is. It really messes with my week. It really messes with my week. I also want to validate your point around guidelines are different based on the body, because I'm in that weird zone where I skew early. So a lot of the guidelines are written for postmenopausal women, where the average median age and breast cancer survivorship is in the 50s and 60s, and it's not in the 30s, which is where I am. And I have high density breast tissue, so it causes all I like. You know, there's a reason our podcast is called "The Patient from Hell," because I definitely check off a few of the problematic areas inside our healthcare system. So I fully understand the intent of the study. Before I ask you a few questions, though, can you talk a bit about surveillance versus screening?
Yeah, it's a great question. And I think many people kind of confuse the terms, but they're very different. So, surveillance is what you do to follow a person after they've been treated for their cancer. Whereas screening, particularly lung cancer screening, is taking a high risk group to develop a lung cancer and trying to look at them to identify a very early cancer, which would be highly treatable.
Yeah. On surveillance and screening, my follow-up question for you though is the testing modality the same?
It is now. You know, in 2024, the overwhelming, you know, test is a CT or a CAT scan.
Got it. And it's a low dose CT, if I remember it right, right?
It's a low dose CT for lung cancer screening. For surveillance, to be honest, there are many types of CTs used, typically not low dose. Typically what's called a thin cut CT, either with or without contrast.
Hmm. I see. And is the choice of what screening modality to use dependent on the type of cancer? Like how is the clinician deciding what type of
Yeah, so again, for surveillance, right? So for screening, it's a low dose CT scan. And there's a great, you know, study in the New England Journal of Medicine, and that's what everybody follows. And finally, the US Preventative Task Force has taken it up, and Medicare and all insurance companies pay for it. So screening is, you know, kind of separate from our study. Our study is purely on surveillance, people who were treated for lung cancer, and then how often should we follow them? And it really is up to the physician. Honestly, the physician often orders the CT scan. You know, some of this is up to the radiologist.
Mm-hmm. And I'm assuming availability of the imaging, or is it mostly available everywhere?
These tests are readily available in the US. Yeah.
Okay. So now coming back to your research. So you did the study to look at the impact of surveillance 3, 6, 9, and 12 months, if I remember this right. Or 3,
Yeah,
6, and
3,
12.
6, and 12. So we call it surveillance intensity, how often we see patients.
And what did you find?
We found that survival was not associated with how often we see patients. And obviously it's a retrospective study, so we don't talk about causality, and it makes sense, right? There's nothing about how often we see patients that would, cause the outcome. But the idea being, can we really improve the outcome of a patient if we catch it earlier? And unfortunately for lung cancer, by the time lung cancer has spread, whether we're catching it at 3 months or at 6 months or at a year, unfortunately does not make a big difference in the outcome for that patient.
Can you say that one more time? Because I think what you just said is super, super important. And I think changes based on the, like in breast cancer, that may not hold true. So I'd love for you to talk a little bit more about that.
Correct. So we're talking about lung cancer. Very important, right? Breast cancer is a very different type of cancer, different biology. So it's really important for people listening not to apply this to all cancers. And you can look at those studies. I can give you the senior authors' names for people who are interested. But for lung cancer, if you were in the high intensity surveillance group every 3 months, as opposed to less frequent surveillance every 6 or 12 months, your outcomes were the same.
Based
And
on the imaging, primarily CT and the different types of CT, correct?
well, based on actual patient survival. So we looked at actual 5-year survival. And so importantly, it's really hard to do these studies. We actually tried to have a prospective study funded, and you can imagine it takes an enormous number of patients who you would then follow for a long time. It's really expensive.
Yeah.
So, frankly, the NIH and PCORI were not really interested in funding it. And I can understand that. So we did a retrospective study. And it's important because when you talk about surveillance, you're talking about asymptomatic patients. They feel well. They don't, in lung cancer, they don't have any new cough or new shortness of breath or new headache or something that might worry you that the cancer is back. So surveillance refers to somebody without symptoms who's just coming in for routine imaging. And the problem with trying to look retrospectively is you really don't know why the patient's having their scan for most studies. And so the beauty of what we did with our groups in breast and colorectal and prostate is we used the National Cancer Database, which goes through the Commission on Cancer. And we were able to do a special study. And so each hospital that participates actually looked really closely at 10 patients. And they helped determine why they had their imaging. And so if you only have to look at 10 patients, you can go through their chart, their medical record, and really come up with why did they have that scan. And so if it's just routine surveillance, great. But if they had a new symptom, a new sign, that's not really surveillance. That's very important.
I see.
So it makes these studies hard to do, which is why there's not a lot of high quality, information out there.
I see. Okay. Dr. Kozower, I'd love to learn about, so you've done this study. How are you applying it today? So we have patients, essentially the really intense surveillance and the 6 to 12 months don't seem to make much of a difference. So when a patient shows up, early stage non-small cell lung cancer, they've completed treatment, what are you telling them and how are you working with them to develop a surveillance plan?
Yeah, it's a great question. So surgeons typically have followed patients less frequently than medical oncologists. And so in my own practice, I see patients either every 6 months or annually. We never see patients every 3 months following lung cancer unless there's a finding that
Hmm.
we want to follow up on. But just the general pathway
Yeah.
is every 6 months for the first 2 years, and then annually out to 5 years.
Interesting. So let's say I'm a stage 2, stage 3 non-small cell lung cancer patient. In that population, given our previous conversation, there is systemic treatment part of the treatment plan. So presumably, the medical oncologist is, for lack of a better word, the quarterback for care, and the patient is coming to you for the portion of surgery. Is that right?
That's maybe right, and it may not. So I
Correct.
have certain patients that I'm their primary doctor. I think in general, patients with more advanced disease, stage 3, probably see their medical oncologist
Hmm.
more than the surgeon, but not always.
Got it. And then in stage 1, is the reverse true?
In stage 1, typically they don't see a medical oncologist
At all, right? So they're coming
at
primarily
all.
to you, and you're essentially quarterbacking the entire experience. And then at the end of the 2-year mark, is there a, no, I know it's not formal, but like an informal handoff back to the primary care doc or the pulmonologist, or is there another clinician that sort of takes over?
Yeah, that's a great question. Yeah, in the US, there's no great uniform system. We see our patients out for 5 years. More and more, patients are willing to travel for surgery, but they don't necessarily want to follow up with us, here in St. Louis at Washington University for their CT scan. And so depends on who is referring the patient, who lives near the patient.
Mm.
If you have a capable pulmonologist or medical oncologist near you, that's totally appropriate to follow up close to home. And so we do that frequently.
Interesting. Okay. Okay. That is super, super helpful. Is there anything about the study that I should be asking you that I have not asked you?
A few things. What are the other benefits of surveillance? And this is true with all types of cancers, but particularly for lung cancer, the greatest risk of a new lung cancer is actually a previous lung cancer. So your exposure history, your genetic makeup, you have a high, predisposition for lung cancer. And so it's about, a 2% risk per year or so of developing a new lung cancer. And so one of the reasons to be following patients is that you're actually doing a type of lung cancer screening. You're not looking for recurrence of the cancer that was treated, but you're looking for a new cancer.
There were so many things you just said that I have so many follow-ups to. Okay, can we take a just 101? What is the risk of getting lung cancer for the average American? Ballpark.
It's a great question. It's a small number. I don't have a great number off the top of my head because that's, it's a very small number if you think about, 450,000 lung cancers. What, we would need a denominator of the US population,
Yeah.
to come up with the risk. But it's, per year, incredibly small.
Okay, so the reason I asked you that question is if I heard you right about the 2%, that's in the population that has already had lung cancer. So it's in the survivor
Correct.
population.
Correct.
And the recurrence you're talking about is not a spread, it's a local recurrence. It's not even a local recurrence, it's a new primary, is what it sounds
Correct.
like.
Correct. And so then the other important question that we didn't talk about is, what's the chance of lung cancer coming back? And
Correct?
that we call recurrence. And so unfortunately, it's a higher number than people like to hear. Even for stage 1 lung cancer, historically, it's about 30%. So
Oh,
the earliest stage of lung cancer, about a third of patients have the cancer come back. And about a third of those come back what we call local regionally, in the lung or the lymph nodes. And about 2/3 are systemically, meaning other organs, and they got there in the bloodstream.
mm,
And fortunately, those numbers are starting to change significantly. So
mm,
there was, some great studies, the Early Lung Cancer Action Project, and from
mm.
patients in the lung cancer screening program, the earlier we find these lung cancers, the better patients are doing. And so I think the recurrence rates that we see in the future are fortunately going to be much better than they are now. And we see that in the published studies looking at the lung cancer screening population.
Dr. Kozower, I'm having a bit of a moment of cognitive dissonance. So I maybe I can tell you what I'm struggling with, and you can help me understand it. Um, at the beginning of the conversation, we sort of segmented patients: stage one cohort, stage two, stage three. There's differences, but for this question, I'm going to put them together, and then you have stage four. So in the stage one setting, patient comes in, primarily do local treatment, right? You're removing the tumor plus some margin. But then I'm hearing that of that population that has the stage one, a very large majority are getting a recurrence where it has spread. So
Not a large majority, 30%. So 2/3 of patients are cured, 1/3 of patients, but it's a larger percentage than you would like. But
so
not,
of the
not
30, yeah, of the 30% that has the recurrence, there's a 1/3, 2/3 split of what type of recurrence, right? So it's almost like 66% of the 30% have a sort of stage three, stage four second diagnosis, it sounds like.
Yeah, really systemic. So really stage four. The most common places to spread are the brain to bones, other areas of the lung, liver, the adrenal glands.
So maybe I can ask you. I think I know the answer to the question I'm going to ask you anyway, which is, if that is true, why are we not doing systemic treatment up front in that
Great
population?
question. It's a great question. So the issue with that is that historically the treatments we've had for systemic disease have not been that effective. So that's been a huge problem. Okay.
I see.
And fortunately now we're starting to see, the development of, targeted therapies for specific, mutations. We're starting to see different types of therapies. So not just chemotherapy, but something called immunotherapy, which stimulates the body's immune system to help fight the cancer.
Yeah.
And so these things have dramatically changed the paradigm of how we treat lung cancers. And there is talk now. So we talked about the checkmate study, earlier in this talk. There are patients with stage one called stage 1B, larger tumors,
Yeah.
who were enrolled in the study, but there frankly weren't enough of them to see a real advantage. But there's a huge interest. I can tell you the pharmaceutical, industry, and appropriately so. There's obviously a lot of potential benefit for patients if we can identify which of these patients, even with stage one lung cancer, are more likely to recur, then what can we do to help them up front? And so those conversations are ongoing. I can tell you there's some studies being designed.
Got it. Got it. Okay, so I'm going to draw a parallel to breast cancer, because I think there is a nice parallel here, which is in early stage breast cancer, we do have, for some molecular subtypes, oncotype DX. Right? You have this upfront test that gives you some sort of score on the odds of a recurrence. And if you score high on it, that usually is one of the trigger points for the clinician to often offer systemic treatment, even if the tumor is small and locally available. So it sounds like there's not really today the equivalent of that in lung cancer.
Correct.
Got it. Interesting. Okay, that was fascinating. I learned a lot right now. Thank you. I obviously don't know anything about lung cancer, but okay, I want to go to the future of lung cancer. I think you mentioned a couple of things. I think my specific question there is about liquid biopsies. And I wanted to tie it back to liquid biopsy role in the role in surveillance. And I'd love for you to talk about where that is today and where you see it going.
Yeah, it's a great question. I mean, theoretically, if we could take a sample of a patient's blood and be able to identify, very small amounts of tumor or tumor DNA or whatever the compounds are that we're looking for. It would be tremendous. Unfortunately, despite the numerous companies that are out there and promoting the test, there's nothing being used in mainstream right now. They are becoming available. Certain insurance companies are more likely to pay for them than others, and it's because the data supporting them. They're also very expensive. And so, our healthcare system's not doing particularly well on, the kind of efficiency of our, healthcare utilization. So before we use these really expensive tests, we have to have, good data that they are reliable, that they improve outcomes, and we're just not there. In the future, it makes a lot of sense that these are going to, they're going to be out there. Currently people look at ctDNA. Can we look at the amount of DNA in the blood from the cancer, and can we understand what's going on, and can we use that as a marker of treatment and recurrence? And what we're finding is, for example, in stage 1 lung cancer, it's really not been helpful because typically, ctDNA is undetectable. But as the burden of cancer goes up, then it's more helpful. And so there's all these things in play. So I do think in the future, these things will, their molecular testing is really just at its beginning.
I'm watching the clock, Dr. Miller, and I'm going to try and wrap up. But my question for you on the wrap up is it's more on the emotional side for you. And the reason I asked that is we've had a few guests come and talk about lung cancer recently on our show, and one of the themes I have been hearing is it sounds like lung cancer is sitting at this funny inflection point where so far the story has been largely sad. Patient gets diagnosed with lung cancer and the odds are just not in your favor. But now with the advent of molecular diagnostics, targeted therapies, immunotherapy, the story and the narrative seems to be shifting. I'd love for you to talk about that. Do you see more hope and optimism for lung cancer today and in the future, or is it, from your perspective, kind of the same story that played out for
absolutely.
years?
And taking a step back, right? Like our government, our insurance companies have not paid for any lung cancer screening until this decade.
Wow,
So
I did not know that.
it's a little crazy, but if you think about it in general, smokers have not been a very sympathetic group, and I'm sure that comes into play. But now we're also seeing, it used to be that over 90% of lung cancers were in smokers. And unfortunately, we are seeing a rise in non-cancers developing lung cancer. 15%, 20%, and rising, particularly in young women. And so it changes how people look at that. But right now, lung cancer screening is available to everyone. It's available to, private insurers, Medicare, most states, Medicaid. But the utilization of lung cancer screening is awful. So for people who do it, it is extremely effective. It's actually the most effective type of cancer screening. It's better than colonoscopy for colon cancer, better than mammograms for breast cancer. But if you're a primary care doctor and you've got to talk to a patient, it's really difficult because you've got to screen for all these types of cancer. You got to manage blood sugar and their weight and everything else. And now, if you start ordering these scans, about 25% of patients will have a nodule. They'll have a spot on their lung, 1 out of 4. The good news is fewer than 5% of them are lung cancer. But a lot of people have spots in your lungs. So, I'm getting off track a little bit, but I'm making this plea that people need lung cancer screening. That is the single best thing, particularly if you're at high risk. If you're over age 55, you have a 20-pack year smoking history. The best thing you can do for yourself is quit smoking, but at the same time, you want to get lung cancer screening. Okay, so that will save a lot of lives. because the vast majority of patients will be found at a very early stage and highly treatable, likely curable.
Wow. Wow. Okay. I think you just blew my mind at the very end. I had no idea that the cohort where there is a rise happening is young women. Wow. Okay. I'm gonna reinforce your last statement as the summary of our podcast today, which is lung cancer screening is the most effective way of screening for any type of cancer, which I also did not know. And of course, if you have risks, you should get screened. So, on that note, doctor, anything else you want to add to that?
No, thank you very much. I appreciate it. You'll see for those patients listening who do have lung cancer, there are, going to be many different algorithms and will depend on your personal risks and also on kind of the practice patterns where you are. But I think it's very reasonable if you have questions, you could ask, the physician caring for you.
Thank you so much. We really appreciate your time for coming on this episode.
My pleasure. Thank you.
Thank you. This episode was supported by an award from the Patient Centered Outcomes Research Institute.